Good afternoon. I'm Dr. Eugene Heslin, First Deputy Commissioner and Chief Medical Officer for the New York State Department of Health. I'm joined today by Dr. Mary Foote, the Medical Director and Health Systems Support Branch Director for New York City's Department of Health and Mental Hygiene, to present today on monkeypox updates. Several housekeeping issues. Today, we will be presenting the slides with voiceover. And as such, you will not be able to see us, but you'll be able to hear us banter back and forth as we do as we go through the presentation. We are going to be presenting on updates on current monkeypox outbreak, journal articles of interest, some pediatric considerations, the EUA expanded access of Jynneos vaccine, and then on resources. As with our other presentations, we are going to attempt to keep this to 30 minutes. And thank you for coming online today. Next slide, please. Slide, please. So New York State has the record number of cases for any state. As you see, we are at 3,073 cases. Of course, New York City has the vast majority of those cases at 2,885 cases. We now have monkeypox in 24 different counties throughout New York State, and largely surrounding New York City in the Westchester, Nassau, and Suffolk regions. But we are seeing and do expect that most, if not all, counties will eventually have monkeypox. Dr. Foote?
Okay, and just looking at New York City specifically, we're at getting close to 3,000 cases. Next slide. And this is just comparing the New York State data outside of New York City, and then to the right is the New York City cases. New York City cases, we do seem to be seeing what had initially been a leveling out over the past couple weeks, but now we do think that we are seeing a sustained trend of a decrease in daily case counts. And just to be clear, the area in the gray is data that's still filling in, but we do seem to see a trend that we hope will persist. And looking at just a quick high level points about our data. So we are continuing to see cases, vast majority are among men who have sex with men between the ages of 18 to 44. So sort of right around the 35 to 40 is our median range. We have had 2 pediatric cases now that have been identified, one outside of New York City and one within New York City. And for race ethnicity, for New York City, we have a higher proportion of cases among people who are Latino compared to people who are white or Black. And for New York's, and few reports of cases, both for New York City and New York State, that have required hospitalizations. Those that have are very vast majority are for pain management and symptom control. And we have not had any associated cases among healthcare workers. And Dr. Heslin, if you want to comment on the New York State demographic trends.
Largely similar. We are seeing that our white and Latino population make up about 30% of each of our populations, and our Black population about 17%. I'll also caution to note that there's a large majority of people that do not choose to self-identify by race or ethnicity. So again, we are dealing with numbers that are literally less than 10% of New York City. So I think that's where the action's at. Right, please.
And the links on that page, we now have both New York City and the New York State Health Departments are both posting regularly updated demographic data on our cases and vaccinations. So looking at New York City's vaccination data, so we are very excited to say that we have now given approximately 70,000 doses of the vaccine, and these are, for us at least, all first doses. And this is a deeper dive looking at our demographics of who has received vaccines by race and ethnicity breakdown. And so just to kind of orient you to this. So the lighter colored bars are basically our estimates of who would be eligible based on estimates of men who have sex with men or transgender, nonconforming, non-binary people who have sex with men who report two or more sexual partners in the past 12 months. So those that we would consider potentially at higher risk and eligible for post-exposure PEP++. And then the darker colored graph is those that have actually, the percentage that have actually received vaccines by race ethnicity breakdown. So I think what is really most striking here is Hispanic population have received a higher dose percentage of vaccine doses compared to their eligible population. And in addition, I think what is most notable is for only 12% of the vaccines have been given to people identifying as Black compared to 31% eligibility criteria. So we really acknowledge that there is significant amount of work that needs to be done to close these gaps. Next slide.
And in New York State, what we're seeing is a somewhat different trend, but again, very concerning. So, and again, this is available on the public website, and we're looking at actually total cases that have been identified by race and ethnicity versus those vaccinated by race and ethnicity. And today we have completed approximately 8,000 vaccinations. And what you see is a similar trend where we are not necessarily matching our race and ethnicity caseload to the people that are being vaccinated. And so there's a number of different things that both the city and the state have started to do to start to address these race and ethnicity disparities. And next slide, please.
So acknowledging what we are seeing in the data, that there are definite disparities that need to be very actively and aggressively addressed. We have taken, some pretty active steps to try and improve vaccination rates among communities that are seeing disparate rates of coverage. So, for example, in New York City and other jurisdictions, I believe in New York State, we are partnering with community-based organizations and healthcare organizations that serve New Yorkers with within the prioritized population. So that would be medically at higher risk, and also particularly communities of color that are not getting as good vaccination coverage as we hope they would. So that's really a direct response to try and build trust and engage these populations to get vaccinated and have access to vaccinations. And in addition, New York City has just recently announced we are granting $5 million worth of funding for community-based organizations, specifically those that work with BIPOC, high-risk men who have sex with men population, that we are hoping that can build community engagement platforms, educational materials that are really appropriate and specific and speak to these communities to, promote them in, vaccination equity efforts.
Yeah, and in New York State, what we've done is we've done a focused look at communities throughout New York State that have high-risk populations. And through our AIDS Institute, we've expanded vaccine outreach, providing vaccine for those community outreach groups, in addition to what we normally provide to the 14 local health departments that are distributing vaccine under their own methodologies, to include communities in the Southern Tier, Finger Lakes, Mohawk Valley, and Long Island. And we continue to look at and think about at-risk communities that are not being covered as well as we would like, and to try to focus this equity lens, both through these community groups, but also through direct patient outreach. So I think what you're hearing is both city and state have recognized the need to put a very high focus on equity and making sure that we're getting to the right populations as we are continuing to evolve and roll out our vaccine strategies. It's just important.
And this is just really wanted to point you out. There are some new data pages that the CDC has posted. So there's now a little more granular data on laboratory testing, case demographics and symptoms. There's a new page on Mpox patient data, demographics, and a behavioral survey, which we'll take a look at right now. Next slide. And so this is an interesting kind of set of graphics that we thought was worth highlighting. So this is from a behavioral health study that's been done out in coordination with Georgia and the CDC at Emory University, doing outreach to get better information on behavioral changes in response to monkeypox among higher risk men who have sex with men populations. And what they have seen is that from the responses, 48% have reported reducing the number of sexual partners in response to monkeypox outbreak, and 50% reported reducing one-time sexual encounters, and 49% reported reducing sex with partners met on dating apps or at sex venues. And, you know, I think the encouraging trends that we're seeing, you know, in New York City and hopefully in other higher transmission areas is really a reflection of, you know, I think multiple factors, including, you know, vaccine efforts and also, I think, really great work from the community in, you know, education, outreach, and changing behaviors until they were able to get vaccinated. So I think it's the work is showing that we're making headway on this. Next slide.
Yeah, and want to talk a little bit about children and adolescents. We know that school is starting. We know the colleges are starting up. There's a variety of different venues where we're going to see more congregate settings. But let's be as clear as we can. There's an extremely small number of pediatric patients. In fact, in New York State, it's now 2. It was 1 up until yesterday with monkeypox infection. Kids get rashes for lots of reasons. Certainly, monkeypox would not be in the highest risk differential, and you have to think about what you're doing when you're testing a child. You want to make sure that there is appropriate risk and, you know, characteristic lesions when you test somebody. This really does have a broad impact on people. Testing takes several days to get back from a lab. I'll just comment about commercial labs. We no longer have the majority of testing going to our public health labs. In fact, Wadsworth is only doing approximately a third of the testing. You don't need permission from your local health department to test somebody, but we do urge that you use good clinical judgment when you do this type of testing. It puts people at risk for stigma. It puts people at risk for missing school or work. And so, as such, think and test appropriately. Think about the risk factors. Make sure that you are taking into account all of the potential demographics. Slide, please. We are seeing increased positives because, again, we are seeing pre-test probability going down, and people are testing everything. You know, if it's poison ivy, could it be monkeypox? Is it, if it's a, you know, a herpetic lesion, could it be monkeypox? If you have index of suspicion, testing is appropriate. If you don't have a high index of suspicion, you probably need to test and treat for the things that are more likely to be in your environment. Again, don't need to check with us to go ahead and do commercial testing. We do receive many phone calls about many things. That seems to be a popular subject. Do we need to check with you to confirm in order to test? The answer is no. What you do need to do, though, is if you do a case of monkeypox, you need to report it to the local health department. It is still a reportable illness. And although, you know, that overwhelms some departments, we still unfortunately do have it as one of our reportable illnesses. Slide, please. Next slide. Now to the fun stuff.
So there have now been two studies recently published out of Belgium and then a group in Paris. Clinicians that are collecting samples at sexual health clinics in these communities. And these are based off of results based on routine anal rectal swab screening as part of, you know, routine sexually transmitted STI screening among MSMs. They also tested routinely collected samples for monkeypox PCR. And so the punchline is, you know, they're really looking for, you know, correlation, positive PCR correlation with symptoms to see if there's any, you know, potential for positive PCRs in patients without symptoms. So the risk for theoretical asymptomatic transmission. So in these populations, they did, in a small amount of samples, identify PCR positive anal rectal swabs for men who were not reporting symptoms at the time of collection. So in the Belgium study, you know, the numbers were small, 3 out of 244 men tested, but, you know, that is notable. All at that time denied having symptoms in the week before and after the sample was taken. None had reported any known exposures to monkeypox, and as far as they could track, none of the contacts developed monkeypox, and follow-up samples taken 21 to 37 days later ended up being negative by PCR. And in the Paris study, it was a higher proportion, 13 of 200 men that were tested positive without any reported symptoms. And only two of these subsequently presented to the clinic with symptoms. So at least, you know, 11 as far as they know were potentially infectious without symptoms, which could certainly have implications from public health control perspective.
Next slide. Oh, next slide. There it is. The MMWR. There you go. This was a pre-publication on August 19th of this year. And it was about monkeypox and, you know, surface contamination. And what they did with a small sample, 2 people, they looked at 30 specimens in a home on both porous and non-porous surfaces. 21 of them yielded positive PCR. Yet at the same time, none of them yielded a positive culture result. So there were porous surfaces like cloth and furniture, and non-porous surfaces like handles of switches and chairs. But at the end of the day, we didn't see any live virus. So, you know, it brings, you know, because there's always a question of how transmissible is this? Are we going to see, you know, you bump into somebody or you touch something? The answer is you still need to use good hand hygiene. You need to use appropriate, you know, gloves and contact precautions when you're dealing with somebody that has no monkeypox virus. But at the end of the day, this is not going to be something you get because you bump into someone on the train. It's not going to be something you get because you have been necessarily in an environment that someone else has been in previously. So doing routine household cleaning, make sure you're doing your laundering of your bed materials, that's important. But we're starting to see a difference, you know, in this in terms of risk of transmissibility. It does require skin contact, it does seem to require significant contact. That's particularly important when you start thinking about, talking to your younger people, your college-age students, and your communities. So, we're always fearful of new and different, but I think that as you're hearing over the last several, if not many weeks, let's start putting our fears aside and dealing with the reality of what this virus really is. And we'll now switch to vaccine updates.
All right. So looking at our new intradermal Jynneos vaccine approach, so many of you probably heard recently that the federal government has changed the vaccine strategy to implement an intradermal administration as part of its national vaccination strategy to basically expand limited supplies. So the rationale here being one that with intradermal administration, you can use a smaller dose, so about a fifth of the dose as you would use in subcutaneous, which would stretch existing supplies significantly. And this is also based on the rationale that, there was previous studies looking at immunogenicity between the two administration routes, and it was pretty comparable among the studied group. Next slide. Oh, and I will say also two other changes in terms of the EUA. So one is children under 18 years of age were also allowed in an EUA to receive the Jynneos vaccine, but that would be only given via subcutaneous route.
So when we start to look at the results of these studies, we do see that it seems to be immunologically similar, whether it's ID or subcutaneous. We do know that there is more of a reaction in the intradermal dosing, and that about a third of people did have some discoloration at the administration site. Can you switch to the next slide there, Mike? In this one study, you can see the list of different type of events, effects, and side effects. What's important to note is in the ID intradermal dosing type regimen, about 20% of people dropped out of the study, and 10% of them dropped out because of reactogenicity. And in the sub-Q, about 6.5% of people dropped out. So the reaction at the site is real, and it is common. 99% of people had erythema and induration at the site and some itchiness. And so when we are looking primarily at using the same site as you might expect for a PPD, which is the volar surface of the arm, but in fact, there are going to be other alternate sites that could also be potentially offered. For example, the back underneath the scapula or shoulder blade. We know that intradermal injections have been done, and in fact, for allergy testing for many years' time. So it's not that it's uncommon to see intradermal injections. It's just that we haven't typically used them in our environment. So lots of new things, but nonetheless, what this does is it expands, our ability to provide more coverage to more people. So that's a good thing. Next slide, please.
And so now, at this point, New York City and New York State have both announced that we are adopting the intradermal strategy and training for, since this is a little more technically complicated method, there's a lot of work going into training vaccinators in preparation for rolling this out broadly. And during we're doing a lot of work with community partners, community-based organizations, and healthcare providers just to educate about the new route, try and, explain the rationale, and give guidance on best method administration for each person. Because, as we said, there are some people where we would preferentially give subcutaneous as opposed to intradermal. So just making sure we can, identify the right people are getting the right vaccine administration type. And the punchline for New York City is we will be announcing information about second dose availability very soon, now that more doses are available. Next slide.
Yeah, and New York State is going to be August 29th going to a full dose intradermal strategy. Many organizations are already doing that. There is guidance that is being released in terms of the intradermal strategy, as well as training videos and training slide decks, which are being released. Either some were released last night, some are being released today, some are being released. Not sure there's anything else on this slide, so let's move on. And what we did do for you is put links in to how to do a sub-Q injection, how to do an intradermal injection, and what are the ways to prepare and administer the vaccines, as well as some administration errors that could occur. And these webinars are available online, and you can download these, as well as these are active links. Next slide, please.
And this is just information on where to find the vaccine appointments for both New York City program and for New York State, so you can follow those links. And just the major update for tecovirimat or Mpox, there was an announcement by the CDC last week that there was another significant streamlining of the IND protocol. And the consent form was streamlined, so there's now a short version, and a Spanish translation version was also posted, which was great news for all of us. And the patient intake form, the initial form, has also been streamlined to 2 pages. And I think notably, there had prior been 2 required follow-up visits, one during treatment, one after. The during treatment visit has been eliminated as a requirement. The after treatment visit is now highly recommended, but not required to initiate treatment. And now providers have up to 7 days to return IND paperwork for a patient after initiating treatment. And these are just, go ahead. And these are just links directing you to information on how to access Mpox for your patients for both New York City and New York State.
Yeah, and New York State has established a network of monkeypox treatment providers. These are institutions that are located in every region of New York State, and how to access these institutions. This is meant for providers. This is meant for providers who have patients that either have confirmed monkeypox or have tested for and are highly suspicious for monkeypox, for people that are in need of treatment with tecovirimat. Frankly, it's not for people to call up to say, I have somebody that has a rash, what do you think? But these are centers that have agreed to have pre-deployed tecovirimat available, as well as clinicians available for the evaluation of patients to be able to provide tecovirimat. As you know, it is still a research drug under the IND protocol, and as such, it's a little more difficult to provide outside of the community. New York City has a unique relationship that's able to do that. We are still working on it. So this is what is now available throughout New York State. Next. Finally, as we always end our talks, these are resources that are available. We both encourage you to go to the monkeypox sites. There is a large amount of data and updates that are available between our webinars, and with active links to all the documents that you have seen today, as well as many other documents and information for you used for your patients and to share with other providers. I'll give Dr. Foote the ending word today, but thank you for dialing in today. We'll probably do another one of these webinars in another couple of weeks, or if there is significant information that changes in between.
Yeah, no, I just want to thank everyone for joining and for all the support to your patients and support to the public health efforts. And, I think we really are starting to see all those efforts make a real difference in transmission. So thank you for all that you do, and thanks for joining, and we will hopefully see you soon.